Thank you, Cecilia. So welcome everybody remotely. I'm sorry that you cannot see me. Um, so the title of my presentation is to talk about pacemaker therapy, specifically just focusing on recognizing and managing complications that can arise from these procedures. And the second part of my presentation is to talk about pacemaker timing cycles, which are important for you as clinicians to be able to recognize what the normal pacemaker ECG looks like and what the abnormal pacemaker ECG would look like. So these two topics are particularly, hopefully, more practical so that you can apply them to your daily practice. I have no conflict of interest to disclose. So from the complications side, we just want to talk about some of the common complications that you may see in pacemaker patients, discuss the recognition and prevention considerations to minimize such complications, and as I mentioned, to talk about pacemaker timing cycles. So the complications that can come from a pacemaker procedure could generally be generated from a hardware issue. So one of the common hardware problem is the lead. The lead is the weak link of the system. So, you can encounter problems with capture. It may not be capturing or it may not be sensing well. It could also be where the lead is positioned that in addition to pacing the heart muscle tissue, it could also be pacing some extra cardiac tissue as well. And then a not so common problem is lead dislodgement. So capture problem is a significant problem because if the pacemaker is not capturing, it could lead to a delay in escape rhythm or no escape rhythm. So this ECG is just showing you an example of a pacemaker that is pacing in the ventricle. And then there's a loss of capture for quite a significant number of beats, and the patient did not have any intrinsic rhythm to come out until towards the end of the tracing. So that can cause remarkable symptoms from the patient. And what I want to cover also here on this strip is the concept that you can also have what we call overdrive suppression of the escape rhythm. And in such a case, the rhythm, it just takes much longer to come out when you abruptly stop pacing. So this is something relevant for bedside temporary pacemaker checks. If the surgeon or the CVS fellow suddenly just turns off the pacemaker, you can actually it could take much longer for the escape rhythm to come out. Whereas if you actually slow down the pacing rate gradually, you allow the escape rhythm to kind of accommodate to the slower rate, and therefore it's more likely to emerge. And I'll show you more example on subsequent ECG. So in such a case, we would consider such patient as pacemaker dependent. So pacemaker dependent is defined as a patient having significant symptoms upon cessation of pacing, or if the intrinsic escape rhythm is less than or equal to 30 beats per minute. So here is what we looked at for if a pacemaker, a ventricular pacemaker, is functioning normally, you will generally on the ECG see a spike followed by a widened QRS, suggesting that the pacemaker is capturing the ventricle. A narrow junctional escape is shown on the middle strip, and whereas a wide QRS escape is shown on the bottom strip. Generally, patients with a junctional escape, the junctional escape is fairly reliable. And the rate is usually a little bit faster because it's coming from higher up in the junction. Whereas if you see somebody with a slow Y complex escape, that's usually further down in the ventricle, and such escape rhythms are generally less reliable. And we also can have an unstable escape rhythm. So in this case, you can see the latter part of the strip showing what the junctional escape rhythm is going at. But here you have a much longer cycle in between the two RR intervals. And that's because the junctional escape is having some type of exit block, and therefore it didn't manifest with a QRS here. So when you see this kind of rhythm on the ECG or on a Holter, it just shows that the patient's escape rhythm is unstable and probably should be paced. So here is an example of somebody with, again, profound overdrive suppression of the escape rhythm on a Holter. So that because the lead in this case was having problem, it was not capturing consistently, and therefore when it didn't capture, it really took quite a long time for the escape rhythm to come out or not come out. So what are some of the causes for the loss of capture? Well, if the lead wire is dislodged, then it's no longer in contact with the tissue, and therefore it won't be capturing. If the output that we programmed is not sufficient, therefore you're not capturing. And also as part of the lead maturation process, when there's a lot of scar tissue that forms, scar tissue is very inefficient. And so you actually have to deliver higher output in order to capture the heart muscle. Also, if there's connection issue at the connector block of the pacemaker, or if the lead has insulation break or the conductor wire fracture, all of these could cause loss of capture. So here's an X-ray example of what it would appear on the X-ray if a lead was fractured. So this patient has a two-wire system, meaning a dual-chamber pacemaker, and you can see a gap in the conductor wire where the arrow is pointing, so that's showing a lead fracture. This is another X-ray of lead fracture, and again, this patient has a epicardial type of pacing lead, and you can see that there's a discontinuity of the conductor wire. There should have been a connection here, but you can see that that connection is gone, so the wire is actually broken here. It's quite a large break, so it's very visible. Sometimes the breaks can be tiny and you won't be able to see it well on X-ray. This is another X-ray view just showing that a patient with loss of capture, but it's not because of an apparent lead fracture, but where it's more related to the fact that there's a very tight turn on the wire near the header as it comes out of the header and the pacemaker pocket. So these kind of tight turn are really stress points for the wire, and therefore can lead to problems in the future. If we were to interrogate the pacemaker, we would see data that would support the fact that there's a lead fracture. So the pacemaker will show us a lead impedance trend, which is the resistance of the wire. The resistance gives us information on the integrity of the wire. And so here, this is the trend over a year or so, which is very stable, the measurement. Each dot is the measurement of the resistance of the wire. And then abruptly around August, you can see a huge jump in the impedance reading to really kind of like an open circuit, more than 3,000 ohms. And so that's the point when the wire is broken. And you can see all the subsequent measurements after that is a high impedance reading. We can also see issues with tension on the wire or make break type of fracture from the high rate counter. If you can visualize the two ends that are broken, if they're intermittently rubbing against each other, it can actually generate false potentials intermittently when they make contact. And these are non-physiologic signals. They're just like noise artifacts. And so we might also be able to pick those up in the high rate counter of the pacemaker. And so just one thing to keep in mind when we're looking at the epicardial leads that we use is a bipolar epicardial lead. So this patient actually has two, it's a dual chamber pacemaker. You can see two wires heading towards the pacemaker. The way that the epicardial lead is designed, it's got a appearance of a pseudo fracture, which is not a real fracture. It's just a very small wire that connects the cathode to the main part of the lead body. And so on X-ray, it kind of looks like it's not connected, but in fact, there's a very tiny wire connecting it. So if you see the appearance of the disconnection at this point where the two wires join together, it is not a fracture, it is the design of the lead. Another issue that can cause loss of capture is if the pacing threshold has increased. And so here, this diagram is just showing you that the evolution or the way that threshold develops over time is that so the threshold is usually low at the time of implants, and then during the course of healing, there's inflammation going on and scar tissue forming, so that within the first week or two, the threshold tends to be much higher. It can go up higher. And then eventually, once the healing subsides, it will gradually stabilize down to a stable chronic level. That is usually not as low as the threshold at implant, but still substantially lower than at the peak of the threshold rise. So this is the reason why after implant, at the time of implant, no matter how good the threshold is, we always program the energy output from the pacemaker to be a higher level, a much higher level with 10 times or 15 times safety margin, and that is to accommodate for this evolution of the threshold change over time. And then generally, in about 3 months' time, we expect that all the healing, inflammation, scar tissue, all of those would have been completed. And at that time, we will optimize the pacing output to just sufficient safety margin so that we're not excessively draining the battery. The other issues that can cause thresholds to increase if there are metabolic changes, if the patient is sick, if there's acidosis, or if there's electrolyte problems, those can have changes in the pacing threshold. Minor changes would be things that we do in our daily activities, such as sleep and eating. That's why we always have to program at least a 2-time safety margin just to accommodate for these minor changes in our daily lives. Drugs can also change pacing thresholds. So one of the more notorious antiarrhythmic drug that is known to be associated with threshold increase is the class 1C antiarrhythmic drugs such as flecainide. So if a patient is being started on flecainide to manage their arrhythmias and they have a pacemaker, then it is also a good idea to do a pacemaker check and just recheck the threshold to make sure that there's enough safety margin to accommodate threshold changes. Less likely are drugs such as beta blockers or procainamide or lidocaine to cause any threshold changes. So when we actually do a pacemaker check, we do a test that's called a stimulation threshold. And what we are looking for, and this is also very similar to the temporary pacemakers, whereby the CVS fellow may come and they want to check what the threshold is. And so what we're looking for is the minimum amount of electrical output that is needed to consistently capture the heart. Um, so we want to be, when we're doing this kind of threshold testing, we're decreasing the output gradually until we get to a point where we don't capture, where we lose capture. And so the last output setting where it consistently captures is your threshold value. And the way that you can also determine threshold is actually determined by the output, I guess, is determined by both the amplitude and the pulse duration of the pacing impulse. So you can see here voltage amplitude and pulse duration. The idea is that I can, if I on a permanent pacemaker, we can adjust the pulse width. On a temporary pacemaker, the pulse width is set to about 1 millisecond or 1.5 millisecond, depending whether it's the atrium or the ventricle. So the idea is at very narrow pulse duration, you actually need to deliver much higher output in order to capture the heart. Whereas if you were able to extend the pulse width, then you can use lesser amount of the amplitude in order to capture the heart. This is a useful curve for us because we know that the most efficient point of determining threshold and providing for safety margin is at this point where the curve, the chronaxy and the real base meets right here. So if the threshold is 1 volt, typically we check the thresholds at the pulse duration in a permanent pacemaker at about 0.5 or 0.4 millisecond. And so if the threshold is 1 volt, then we can double the voltage and set the energy level here. And this would be outside of this threshold strength duration curve to provide enough safety margin so that if there's shifts in the curve, we would still be capturing the heart muscle. Is there any questions so far on this point? And if I were to overlap with the energy curve, energy is derived from this formula, voltage squared times the pulse width divided by the resistance. If I were to plot the energy curve, the lowest energy you can see is right at this point where the chronaxy meets the real base, right here. So that's why I call this the more efficient part of the energy curve. So what are the ways that we can ensure that we don't encounter problems with loss of capture? So the first thing is at the time of implant is to make sure that we put the lead and the location is where we get the best threshold measurement, meaning the lowest amount of output is needed to capture the heart muscle. And you want to be rechecking thresholds if the patient is starting on a medication that can change the thresholds. You want to make sure that there's some sort of gentle loops or curves on the wire so that you don't create those kind of stress points that I show you at the header of that X-ray. You don't want to create stress points that can lead to lead tension and cause the wire to break over time. And sometimes if you see threshold rises, in a permanent pacemaker, it's still worthwhile to just continue to monitor it as long as you can provide adequate safety margin to maintain capture. You want to just monitor it and not jump in to say, oh, the threshold increase, we'll have to replace the wire. So we don't do that. So that's what I always tell the pacemaker patients and families, that if we see any changes in the pacemaker clinic, we don't jump right away to replace the system. We always just try to manage with the system. If I have to increase the maximum output of the pacemaker in order to maintain the safety margin, we'll do that and just let the battery wear out if it needs to. And we'll just want to wait and see if the threshold level will come back down again. And sometimes it does. And it saves the patients from getting additional surgery and additional hardware inside the body. So that's the capture. The sensing can also have issues such as undersensing, which means it's not sensing the signal properly, and this could be due to inappropriate sensitivity setting. If the lead, again, dislodged, it won't be able to pick up the signals correctly. If there's insulation break or the conductor wire is broken, if there's scar tissue, or in fact, if there's changes in the native signal, which is the maybe changes in the patient's heart condition, pericarditis or something that can change the native signal and therefore it doesn't sense well. So what undersensing looks like on an ECG is that there's too much pacing. The patient's intrinsic heartbeat is not being recognized by the pacemaker. So you can see here that these first two beats are paced. And then there's a sinus beat that comes in on the third beat, but the pacemaker doesn't see it and therefore deliver the pacing spike into the ST segment. And likewise for the next sinus beat. So this is an example of undersensing. And then the other side of sensing problem is oversensing. So again, similar kind of hardware issue that can cause oversensing problem. In addition, there's also what we call electrical interference. So if there's some electrical noise that's super close to the pacemaker, if it's a very sensitive setting, may pick up those kind of interference, those electrical noise interference, and therefore not pace appropriately. So that can cause oversensing as well. So the way to get around sensing issue is to again make sure that we have the biggest signal, that the biggest R wave or P wave amplitude at the time of implant. And to, again, check sensing if a patient is starting on a medication that can affect sensing thresholds. And also, again, minimizing and watching for any signs of lead tension. What the oversensing will look like on an ECG is that there's not enough pacing going on. There's too long a break in the heart rhythm that is not consistent with what the pacemaker program rate is at. So here on the first two beats, you can see that this interval is what the pacemaker should be pacing at. And then if you march over, it's got a sinus beat that looks like it was sensed. And then when this interval times out, it looks like there's a much longer pause here, and then another sinus beat comes. So the pacemaker did not kick in here as it should have been. Now that ECG appearance can also look the same as a appropriately programmed feature of a pacemaker, a permanent pacemaker. We have a setting that's called hysteresis setting. So that's why if you're looking after a patient, you need to know what the pacemaker settings are, what the low rate is, what the sleep rate is, or the rest rate is. And also if somebody may have this hysteresis feature turned on. So hysteresis is a feature that allows the pacemaker to have a escape rate that is lower than the low rate of the pacemaker. And this is only whenever the patient sees an intrinsic beat. So if the patient actually has an intrinsic beat and this hysteresis feature is turned on, what we're telling the pacemaker is, say, allow the patient to stay in their intrinsic for as long as possible. So to go to even a low rate before the pacemaker kicks in. And if the pacemaker kicks in, it's going to kick in at the low rate of the pacemaker. So let's look at this schematic here. The low rate of the pacemaker is set at 60 beats per minute. This patient has a good intrinsic rhythm at times. So whenever the patient has their own sinus beat that comes through, we want to encourage the patient to stay in their sinus beat, even if it's below 60 beats per minute. So what we did was program a hysteresis rate of 50 beats per minute, so that we tell the pacemaker, if the patient has their intrinsic beat that comes through, let them stay in their intrinsic for as low as 50 beats per minute. And if the patient doesn't come through at 50 beats per minute with their own intrinsic, then pace again. And when you pace, that interval will be at 60 beats per minute. So this feature is really only useful for patients that we know have their own good intrinsic rhythm. If somebody is paced all the time, there's no sense to turn on a hysteresis rate. There's no need for that. Another problem that can happen with pacing therapy is extracardiac stimulation. So, if patient may get diaphragmatic capture or the pacemaker pocket muscle twitch, and it's really because the electrode at the time of implant was placed either close to the phrenic nerve or close to the diaphragm, and therefore when the pacemaker is pacing, it could actually capture those kind of tissues. And when we're talking about the pacemaker pocket muscle twitch, we're talking about that can happen when we actually program the device to unipolar pacing, because in that case, what the pacemaker is using is the electrode, one electrode that's attached to the heart muscle. The pacemaker can itself is the second part of the circuit, is the other part of the circuit. And so the current is actually going through to the pacemaker as well. And so it can actually cause local muscle stimulation. So the way to get around that would be to reduce the energy output as much as we can without sacrificing the safety margin, to see if we can avoid capturing those, the pocket muscle tissue or the phrenic nerve or the diaphragmatic stim. And then very rarely, if a patient suddenly starts to get hiccups and didn't have this before, it could be that the transvenous lead may have perforated. So if the transvenous lead was positioned down in the RV apex and if perforated, then it could be now capturing the diaphragm. So we would need to, do more investigation. So this diagram is just showing you where the phrenic nerve runs on the right and on the left side. And so this X-ray is just showing you one of my patients who actually has phrenic nerve stimulation. And when you look at the X-ray, you can see that the electrodes are actually positioned very laterally and therefore very close to the phrenic nerve. And so our way of getting around it is just to try and adjust the output setting to such a level that we hope we don't capture the phrenic nerve. So one of the ways to get around it is to ensure that at the time of implant, wherever the surgeon puts the leads, we always do a 10-volt high output pacing to make sure that we're not capturing phrenic nerve or the diaphragm. And then I already mentioned about chronically, if somehow we got stuck with a wire electrode that's capturing those kind of tissues, our way of getting around it is just to try and find a combination of the output setting that can minimize this. Lead dislodgement is not a common problem. However, it generally will most commonly happen early post-implant. So that's why, the patient should be monitored, should have the X-ray so that we can compare the baseline lead positions. And the reason why it can happen is because that the distal tip of the lead is not well fixed to the heart tissue, or the anchoring sleeve is loose where the lead is tied down for a transvenous lead. And also something super important that we need to tell the patient is try, especially for a transvenous implant, we tell them not to do any vigorous arm movement activity for the first couple of months, and that is to avoid the lead dislodging. We also don't want the patient to be manipulating their pacemaker pocket because they can actually rotate the device and then pull the lead out of position. So this is an example of a patient who got a ICD. The X-ray here is showing it's a transvenous ICD. So the system is sitting up here in the shoulder. It is an ICD because the device is pretty big on the X-ray, and also you see the defibrillation coil. There's 2 defibrillation coil here. So the lead is well positioned into the RV apex. And about a week later, you can see that now the lead is really pulled back, right? So the device is still sitting in the same orientation, but interestingly, the lead is now much more coiled. There's more lead coiled behind the generator, and we suspect that is the patient just really manipulating the lead, or the patient was doing a lot of vigorous arm movement activity. And so, if you just imagine, bringing your arms, your left arm up higher above the shoulder, you keep tugging at this wire. And so because scar tissue hasn't had time to form yet, so it just pulled the lead back out of position. So for this patient, we have to reoperate and reposition the lead. There's something called Twiddler syndrome, and that's why we also want to avoid this kind of complication. When patients have this unconscious habit of just, because there's something in their chest. And so they just have this unconscious effort to, keep touching it and, rotating it. And eventually it just ties such a great knot on the lead wire. Not only does it pull back, but it's all kink into little knots. And so this wire is totally not usable, right? So the system needs to be replaced in such instances. So that's why we tell them, please don't massage the pocket, don't touch it. If it's itchy, just try and tap lightly on it. And then some rare type of complication with the device pocket that comes up, and it's not very frequent at all. Is the generator may migrate. So if the patient is pushing on it, or if the pocket is super loose, that the generator has room to wiggle, that it might, with the patient's body motion, may migrate downward. Persistent pain. So it's truly an uncommon problem, but it is also a very hard to diagnose type of problem. I did have a patient with a lot of pain around the pocket that we cannot determine what was the cause of it. She even had a repeat procedure to just try to bury the lead down deeper into the pocket because we were not sure if the superficial location of the lead may be irritating some nerves. and it still didn't resolve. So we had to refer her to the pain clinic, and it was just a long course that's not very satisfying because we don't know in the end what caused all her pain problems. Other problems that can come up is hematoma from the pocket, device erosion, and the most significant concern are the erosion and the infection, right? So pacemaker infection, it's actually not a common problem, but it is a devastating problem when it happens because the whole system could be infected, and then we have to take everything out. So the two bacteria that are most common to cause the pacemaker infection is the Staph aureus and the Staph epidermidis. The patient may also have their predisposing risk factors that may predispose them to be more likely to get infections, such as diabetes, or if the patient is on steroid, anticoagulant, or if the procedure is super long, or if this is a reoperation, right? So, for example, when we replace the pacemaker because the batteries run out, those are always at a higher risk of infection. So generally, we do antibiotic prophylaxis, and our approach to antibiotic prophylaxis has changed now. In the previous days, in the old days, we do 40 hours of antibiotics, and now we've changed to just one dose pre-op and one dose post-op, so just the two doses. And therefore, because of that, it also minimized the patient's length of stay in the hospital. The wound irrigation at the time of implant is still controversial, and not every center practices it, but we do. We still use bacitracin to rinse out the pocket at the time of implant prior to closing. This is an example of a patient with the problem of erosion. So erosion is at increased risk if the pocket is tight, if the patient is really small and skinny. And unfortunately, it got to this stage where you can actually start to see some metal. Ideally, we would have loved to have been able to see this patient much sooner than this point. But now at this point, when we can see the label that says Medtronic, it's too late, right? It's the whole system needs to come out, and it's also a increased length of stay for the patient to get treatment for the infection. So really, to prevent this type of problem, we need to be hyper vigilant on sterile technique in the operating room. We need to take into consideration if patients have risk factors for device infection to manage them and to monitor them more closely. The patient and family really needs to be on the lookout for symptoms and to immediately call in if there are any signs of changes. And what I ask them to do is to just call into the hospital switchboard and page the cardiology fellow on call. I know that there are different services looking after wound infection, and there's CVS service, there's the post-op clinic, there's also the pacemaker clinic, and I think having the sort of one place to call, which is the hospital switchboard, and page the cardiology fellow, because then that they can then triage the management and make sure the right people look at the patient and manage it. So this is it for the complication and management part and recognition. There's some references for further reading. Does anybody have any question?
Hello, thank you for presentation. Just a question. What is the smallest wave of a newborn with total atrioventricular block diagnosed in the fetal life to implant a pacemaker in your service?
What is the what?
The wave, the smallest wave that you can implant a pacemaker.
Oh, so when they're really small, I'm sorry, I seem to have lost my Zoom connection. Okay, so I can't see you. Um, so the smallest, so when they're really newborn, they are done in the operating room epicardially, so with the lead attached to the outside surface of the heart. And the smallest that I recall that we have done would be about certainly 1.5 kilograms. But I'm wondering that I also had a baby that was 1.2 kilograms, so it's really, really tiny. And so, I don't know if you're from the U.S. or North America, and there's the baby size pacemaker, which is called the micro knee.
Mm-hmm.
Yep, from one of the vendor, and so that one is the smallest pacemaker in the market, and even that one, when you put it in a 1.5 kilogram baby, it takes really the whole abdomen. It takes up the whole abdomen. Now, unfortunately, at this time, the company is phasing out that micro knee pacemaker, so that they're coming out with a newer one. That newer one will not be as small as the micro knee. The micro knee is it's about the size of like a slightly bigger toonie, and the regular pacemaker are probably double that size. Yeah.
Mm-hmm.
So they're going to come up with something that's kind of in between the micro knee and the regular size pacemaker, which is unfortunate because anything bigger than the micro knee will still be too big for these tiny, tiny newborns.
Mm-hmm. Oh
Yeah.
yes, thank you. I'm from Brazil, and
Ah.
we don't have this micro need. We had in the past, and actually we have a fetal with a low write rate, less than 50, 45, 48, and he's become with heart failure, and I think that 1 kilograms in I don't remember now exactly the weeks of gestations, and we're very worried about it.
Yeah. So now on some of these, and again, it would be good to talk with the CVS team about it. On some of the very small infants, they have done some intrathoracic implants. So the device is actually located inside the rib cavity, the chest cavity. Yeah. And I do have a couple of patients like that, um, that we just have to watch very closely. Yeah. Yeah.
Hmm.
They're certainly very, very challenging. There are
Yes.
risks for every complication that can happen, right?
Hmm.
Erosion, infection, like,
Hmm.
yeah, yeah, agree.
Okay. Thank
Mhm.
you.
Thank you. Any other questions? Okay. So I will proceed to the next talk. Oh dear, I guess I have to find, which is on timing cycles. So if you need a little break, now's your moment. And if you need to grab a cup of coffee, it's a good opportunity. So timing cycles is very important, but it's also a very dry topic. Um, but it's important because it's important for you to be able to recognize very quickly if there are some concerns about a pacemaker not pacing properly. So we're going to go right into it. Are you able to see my screen? Let me double check.
Yes.
Okay,
Yes,
great. Thank you. Okay. So just very quickly, I just want to let you know that in the pacing world, we talk in pacemaker codes, and it's just an easy way for us to reference to quickly know how the pacemaker would be working. So we talk in a letter code such as VVI. Which means the first letter is the chamber being paced, the second letter is the chamber being sensed, and the third letter is what does the pacemaker do when it sees a sensed event. So VVI would be pacing in the ventricle, sensing in the ventricle, and whenever it sees a signal, when it senses something, it should inhibit from pacing. So this is a very straightforward one. And then if it's AAI, it would be operating in the atrium. If it is DDI, then it would be pacing and sensing in the atrium and ventricle. Whenever it sees a signal, it's just going to inhibit from pacing. What you see more commonly is DDD, so pacing and sensing in atrium and ventricle. But when it sees a signal, depending on where it sees the signal, it could either inhibit from pacing or it could trigger a pacing impulse. What you see less commonly is a programming that's OVO or OOO, OAO. And what it is that mode is really essentially the pacemaker is turned off. So it's not pacing anywhere, it's not sensing anywhere, and therefore it's not doing anything anywhere. Sometimes you might see a fourth letter, and the fourth letter really, when it is being used, is just to denote that the pacemaker is capable of rate responsive pacing, meaning that if the patient was doing some activity, exercise, the pacemaker is going to be able to increase the pacing rate in response to that activity. So this is some example strips, and because you guys are not electrophysiologists, we don't need to really dwell into the nuts and bolts of it. However, it is good to be able to pattern recognize the ECG. So we're going to focus a little bit on pattern recognition here. So an AAI pacemaker we talked about will be pacing and sensing in the atrium. Whenever it sees a P wave or an atrial signal, it should inhibit from pacing. So here you can see a pacing spike followed by the P wave, and then the patient is conducting, and therefore there's a QRS. And then another pacing spike, P wave, and conducting to the QRS. So these two pacing beats determines what the pacemaker rate is programmed at, what the pacemaker pacing rate is at this moment of the ECG. So this is how long that interval, that low rate interval is. If you can imagine that it should be out here, that's where the next pacing impulse should be, but it saw a P wave here, and therefore it inhibited from pacing, and it reset that low rate interval. So it reset the low rate interval from this sense P wave, and therefore now the next atrial pacing impulse would be timed from this P wave. Okay? And here you can see that this is a pacemaker pacing in the ventricle and therefore sensing in the ventricle. And when it sees intrinsic QRS signals, it resets the timing. This third ECG strip is showing what a DDD pacemaker would look like. You can see a P wave, and whenever there's a P wave, there's also a paced with a YQRS, so it's pacing in the ventricle. And this is where that triggered part of the dual response comes from. So remember when I said that it depends on which chamber, so the dual response is inhibit or trigger pacing. So when it sees a P wave, it's going to sense the P wave. It's going to time out the PR interval. And if there's no intrinsic conduction, the pacemaker is going to trigger a ventricular pacing impulse in response to that sensed P wave. So that's where the trigger comes from. But sensing that P wave also inhibit the atrial pacing, right? So it doesn't, it recognizes that the P wave came through and therefore it won't pace in the atrium. So that's where the inhibit response is as well. Now, the other side of dual chamber pacing, you can also have it pacing in both atrium and ventricle. That's still dual chamber pacing. You can also be just pacing in the atrium, and the patient may be intermittently conducting to the ventricle. And this is where, remember, we talked about it waits for the AV delay or the PR interval to time out. And if there's no intrinsic conduction at the end of that AV delay, it's going to deliver the ventricular pacing impulse. So here, this patient, while it's waiting for the AV delay to time out, the patient actually conducted, and when it conducts in the ventricle, it inhibits the ventricular pacing. And then the next time the low rate, before the low rate times out, the patient has a P wave that came through, an intrinsic P wave, and conducted. And so it sends both the P and the QRS, and therefore it inhibits the pacing. And then now the low rate timed out, and there's no intrinsic P wave, there's no intrinsic QRS, and therefore the pacemaker now delivers a pacing impulse, and we start all of that again. So what I'm trying to show you on this bottom strip is that any of those 2, 4, 5 beats, any of those 5 beats are still representative of dual chamber DDD pacing. Just like that third strip above, this is classic kind of pattern recognition that this is dual chamber pacing, but any of these would also be consistent, any of these beats would also be consistent with DDD pacing. So single chamber timing cycle. Timing cycle is best understood by first just learning about single chamber pacing, because when we start to look at dual chamber, then everything is kind of like double. So let's focus on the single chamber timing. The important intervals that you need to know are the low rate. What is the pacemaker low rate set at? There's something called a refractory period, a blanking period, and hysteresis interval that we already talked about in the first section. The low rate interval for you as the clinician is the most important number that you should know, because if you are setting up the bedside monitor, you need to know what the low rate interval of the pacemaker is so that you can set your alarms accordingly. So if the low rate interval is 60 beats per minute, you will probably set your alarm at 55 so that, we give it a little bit of wiggle room. Sometimes the monitor may miscount and not precisely count the rate to be 60. It could be 58, it could be 57. So just by setting it a slightly lower, 55, will give you a bit of wiggle room so that you don't get a lot of false alarms. But that's why it's important for you. So the low rate, we also have discussed that it is the interval between two consecutive pacing spikes. So here, and we also, when we talk about we talk about rate, which is like 60 beats per minute. We also need to talk about interval, because 60 beats per minute is, an average of how many beats over a 1 minute period. Whereas interval in pacemaker timing cycles, we have to talk about consecutive intervals. So 60 beats per minute, you need to convert it to interval. So you divide 60,000 by 60 beats per minute and you get what the interval is. 60,000 divided by 60 is 1,000 milliseconds. So that's what the interval is. Between the two consecutive spikes is 1,000 milliseconds. Refractory period is a period inside the pacemaker circuitry, and the purpose of the refractory period is to make sure that if there's any signal that is being sensed inside the refractory period, that the pacemaker will actually ignore it. And the reason is we want to avoid picking up additional other signals, such as like a T wave or other non-cardiac signals. So the refractory period is set to avoid us, for example, picking up the T wave. So if I were to pace in the ventricle, so I would get a YQRS, and then I will have a T wave that follows. If the T wave was really big for whatever reason, and I don't have a refractory period, the pacemaker may double count, right? It may V-pace, and then it's going to say, oh, I sense something, and then it will reset the timing cycle based on that sense event. A refractory period just allows us to program it so that it at least excludes the T wave. The blanking period is something that is at the initial portion of the refractory period, and it's usually a very short period, so usually it's like 28, 40 milliseconds. And the purpose of blanking period is that it is the absolute refractory period, so it will totally not see anything during this first portion. And it's designed to filter out to ignore if the pacemaker for some reason is also able to pick up the pacing stimulus, because the pacing stimulus is such a large signal that it can oversense it. So the blanking period is designed to avoid the pacemaker oversensing the pacing impulse. Now, after the refractory period of the low rate interval, so the low rate interval, so when you have a paced event, for example, the timer in the pacemaker circuit starts timing out a low rate interval. It also starts timing out a blanking period and timing out a refractory period. At the end of the refractory period of 250 milliseconds, that's when the pacemaker sense amplifier is now open to respond to any signal that is sensed outside the refractory period. If it sees a signal outside the refractory period, it's going to then reset the low rate timer. It's going to reset everything. So we call this the sensing window. Anything outside the refractory period and before the low rate times out is your sensing window. So here's an example of the VVI pacing, whereby a pace event starts the low rate interval of 1,000 milliseconds, and then it starts the blanking, it starts the refractory period. So outside the refractory period is my sensing window now, okay? And then before the low rate interval times out, an intrinsic beat comes along. And so that terminates the low rate timer. It starts again another low rate interval from the sensed event. And it also starts a blanking period and the refractory period again. And now from this low rate, new low rate interval is going to watch here now in the sensing window. to see if there's another intrinsic beat. If there is not, then at the end of the low rate timer, it's going to now deliver a ventricular pacing impulse, and then everything starts over again. This is super important for us when we are looking at pacemaker ECG or pacemaker holters to try and figure out what's going on. Is the pacemaker pacing appropriately or not? So these are our principles of how we work out the functioning of the pacemaker. So now we'll go and talk about the dual chamber timing. And so in addition to the low rate interval, we also have what we call the AV interval, which is like the PR interval in sinus rhythm. There's something called a VA interval. There's still refractory period, blanking periods. And then there's an additional interval that's called the upper rate, the max track interval. So we'll look at that as well. So low rate interval, no difference than in single chamber timing cycle. It is the lowest rate that the pacemaker will allow the patient's rhythm to go to. So it's defined by, you can time it from an A to A or a V to V. So here my low rate interval, I'm timing it from the A to A, so from an atrial pacing spike to the next atrial pacing spike. This is my low rate interval. The low rate is 60 beats per minute, which is equivalent to 1,000 milliseconds. So after an atrial pace event, it's going to start an AV interval. The AV interval, the purpose is to watch and allow time to see if the patient has any intrinsic conduction. If they do, then we want to allow the conduction to happen. The AV interval is also the interval that we want to program it so that it's similar to the patient's PR interval, providing that AV synchrony, that atrial kick before ventricular pacing occurs. So generally, we program it to a more physiologic interval, such as 180 or 150 milliseconds. So if within the AV interval, if the patient doesn't conduct, then at the end of the AV interval, the ventricular pacing impulse will be delivered, so that we will have A followed by a ventricular event, AV, AV, right? So that's how the dual chamber pacemaker operates, is that there's always an AV, AV kind of event to maintain that AV synchrony. So here, I just want to show you that after this V-pace event, the low rate interval is going to wait and watch for to see if there's another atrial event, a P wave that comes along. If there is, it's going to start what we call a sense AV interval. And again, it's watching to see if there's any intrinsic conduction, and if there's nothing that comes through from the ventricle during the AV interval, at the end of the sense AV interval is going to deliver a ventricular pacing spike. The VA interval really for us is to let us know when do we expect the next atrial pacing impulse to be delivered. So it is the low rate interval minus the AV interval. This is what our VA interval would be. So this is what is also called an atrial escape interval, because the VA interval is where you're going to watch, the pacemaker is going to be watching to see if there's a P wave that's going to come along. Because you have to remember, every time that the pacemaker in dual chamber operates is atrial event followed by ventricular event. Ventricular event, the next thing that is expected by the pacemaker is another atrial event, right? So that we maintain that AV type of synchrony. The refractory period, there's many more refractory periods in a dual chamber pacemaker. There's refractory in the ventricle, there's refractory in the atrium. There's also a refractory in the atrium that's started by a ventricular event. So this is called PVARP. the atrial refractory period is the AV plus the PVARB. PVARB stands for post-ventricular atrial refractory period. And similarly with the refractory periods is that each of the refractory period has at its initial portion the blanking period as well too. And then I mentioned that there is also an additional interval in a dual chamber pacemaker that's called the upper rate interval. It's also called the maximum tracking rate interval. And this interval, this upper rate, defines the level, the heart rate, at which the pacemaker is still allowed to maintain the one-to-one AV relationship. So, for example, if I have a pacemaker that's set at DDD 60 with a max track rate of 180 beats per minute, that means the one-to-one AV relationship will be maintained only up to 180 beats per minute. So that's this upper rate interval here. And if the atrial rate continues to go faster than 180 beats per minute, the pacemaker is not allowed to track it in a one-to-one manner anymore. It's limited, and so what you're going to start to see is that some of the P's will not be followed by ventricular pacing spike, and so it looks like a type of second-degree block, looking like either Winky-Bach or 2-to-1 block. And I'll have some ECG strips to show you as well. And the reason for that is we want to program it so that we don't want the pacemaker to be, for example, tracking the patient's atrial flutter or atrial fibrillation at really rapid rates. So that's why we limit the pacemaker. So in babies, we would typically have the maximum tracking rate at 180 beats per minute, and in some instances you can also program it to 190 or 200 beats per minute. But the purpose of having this upper rate limit is to avoid the pacemaker from tracking abnormal arrhythmia, atrial arrhythmias really at a very rapid rate. So what happens when the atrial rate exceeds the upper rate is that it's going to start to look like group beating. So in this case, it almost looks like a Winky-Bach type of group beating, right? Because the atrial rate is going so fast that the pacemaker is not going to track all the P waves. So what happens is that it's going to track this sinus P, and then it's going to now wait. The next P wave that sends is not allowed to pace any faster than the upper rate of the pacemaker, which is this interval here. And so the AV interval is actually, you can see it extending like a Winky-Bach kind of behavior, and this one as well extending, and then now eventually the P wave will fall inside the refractory period and therefore not track, and so you have a dropped P that's not tracked here, and then now it's tracked again. And sometimes it may give the appearance of 2-to-1 block, and the reason is that the P is falling inside the PVARB. Every other P wave is falling inside the PVARB, so only the pacemaker is only tracking every second P wave, right? And again, the reason for that is to limit the pacemaker so that it doesn't track something super fast. So if you have a patient, and this looks like a perfectly normal ECG, so if you have a patient that, a baby, for example, that's, tracking along at 160 beats per minute, and then suddenly you see the rate drop down to about maybe 90 beats per minute from 160, so then you need to be suspicious that, could it be that the pacemaker is somehow tracking every other P waves? So that's why, looking at an isolated strip like this, it looks like normal pacemaker behavior. But if the patient here previously was 160 beats per minute, and then here maybe going back to 170 beats per minute, then you got to be suspicious that maybe the patient was having some 2-to-1 block in the pacemaker, and that's probably not a good thing for the baby. And so, if you see this kind of situation, it would be a good idea to call the pacemaker clinic or the fellow to do a checking and maybe adjust some of those parameters. So the key things to remember in dual chamber pacing is that one-to-one tracking occurs whenever the patient's atrial rate has to be below the maximum tracking rate that is programmed. If it's higher than that, then it's going to go into some type of second-degree block where it won't track every single P wave. And so let's look at some ECGs. And we're going to skip crosstalk and safety pacing. So we're going to now look at some of the ECG practice examples, and the answers are given, but it will be good for us to just go through the approach. So in order to interpret ECGs from pacemakers, you need to know the program settings. We need to look for evidence of normal function. So what we're looking for is there capture, and is the pacemaker sensing. So you need to define both events, both functions, to see if they're okay or if they're present. Are there any malfunction? So we talked about in the first part of the talk, some of the malfunctions would be like loss of capture, oversensing, undersensing, and also if the pacemaker rate is appropriate for the patient. So we talked about this when the baby with the 2-to-1 block, right, from the DDD pacemaker. So pattern recognition, this is a test ECG strip. What I want to see is from this ECG, what is the pacemaker mode that would be consistent with these ECG? So I give you various combinations, and we just have to go back and think about the first letter being the chamber pace, the second letter being the chamber sense, and the third letter is what the pacemaker will do in response to a sensed event. So looking at this ECG, we want to first identify which chamber is being paced, right? So you're going to look. We certainly see some YQRS. Sometimes the pacing spike is not a classic textbook type of pacing spike. It could be a tiny spike, but the fact that you have a sort of regular morphology, Y-complex morphology, with a tiny spike in front suggests that this is pacing in the ventricle. The interval between two consecutive pacing spike defines that low rate of the pacemaker at this time. And we also see some P and intrinsic QRS. Whenever there's those YQRS complex, I don't see any P wave in front of it. So what we have here is presence of ventricular pacing. So you're going to look through these down here, these options. Well, it's certainly not AAI because we don't see atrial pacing. Can it be DVI? Can it be, and you can probably eliminate the atrial pacing. So we can eliminate AAI, ADI. Here, VDD, that's a possibility because it's pacing in the ventricle. DDD, remember whenever we have DDD, the idea is that there should be AV synchrony, like atrial event with a ventricular event. So I am thinking that by virtue of not having any evidence of atrial pacing or P wave in front of these YQRS, that we could probably eliminate DVI, DDD, and DDI. So the only possibility it looks like is VVI and VDD because those two are pacing in the ventricle. Let's see if I did it right. Okay. So you can review the answer here based on the way that we worked it through. VDD is something that it is one of the correct answers because when there's no sinus P waves, the pacemaker will still pace the ventricle at the low rate. Okay, let's try this one because I think we have about 15 minutes left. I'm wondering if anybody wants to, from the group, would like to try and work through this one.
Atrial pacing.
Okay. Pacing in which chamber?
Atrial chamber. So AAI.
Okay. Yep. It looks like it could be AAI. Anything else?
And maybe ADI. I don't know.
Uh-huh.
AAI. Yeah.
Okay. What can we eliminate? Do you see any evidence of ventricular pacing?
No ventricular pacing. Yeah.
Yep.
There is no ventricular pacing. All pacing before
Yep.
P wave. So
Okay.
it will be a atrial pacing.
Okay. Okay. So we can eliminate the VDI and VVI then, right?
Yeah.
Okay, excellent. Let's see. So AAI, ADI, DDD, DDI. Now there's one more. DVI. I wonder if we eliminate DVI, no atrial sensing. So you're right. So the answers that we eliminate is VDI and VVI. The reason why it can be DDI is you have atrial pacing, and then at the end of the AV delay, if the patient actually has conduction, then it will inhibit the ventricular pacing. So that's why none of these strips, because the patient has none of these beats, the patient has conduction, we did not see evidence of ventricular pacing. And then these two sinus beats came in early, so therefore it inhibited the atrial pacing. And again, the patient conducted with their own QRS. All right, so this looks good. Would someone like to try this one? It's a little bit different than the previous two. Is there some signs of AV synchrony being maintained?
It is ventricular pacing.
Okay,
and,
good.
So it, answer can be VDD, DDD. VVI.
Yep, very good. VVI, yep.
VVI.
Now, the only thing about VDD is, so if it is in VDD, the AV interval should be consistent, right? Yeah, so whenever it sends a P wave, it should have a consistent. So this one might be a bit of a tricky one where you do need some type of caliper to work it out. So this one, the P wave is a little bit faster, and so the pacemaker is tracking it. And I think this P wave now is it's coming a little bit later. So I don't know if it's because it's timing out, that now it says, you know what, I don't have time to wait for the AV delay to time out because now my low rate must time out. And so this sense AV is a little bit shorter. The AV interval is shorter, is being sacrificed because now the pacemaker says, I need to stay committed to not violate the low rate of the pacemaker. So this one might be a little bit of a tricky question, but I think you are correct that it is most likely it could be VVI or VDD. Yeah, but there is a little bit of a tricky one to it. Okay, and this one?
It's a DDD.
DDD?
Yeah.
Good, okay.
DDI and DDD.
Good, excellent, very good. Yeah, yeah. And one more. So you got the DDD, yep, it could DDD. It could also be DDI. And this one too.
DVI.
This one is DVI. So this one can still pace, also pace in both atrium and ventricle, but it would only be sensing in the ventricle. And so there really, I don't have any beats here for you to sense, but the fact that it's pacing both is also consistent with this one. This one will also work, right? But if I have a PVC here, then I can prove that it's also this confirmed that is DVI. Now, is there any misbehavior from the pacemaker here?
It is double sense is coming before P wave and following the P wave. So double senses, and in between also the pacemaker is sensing.
You suspect oversensing or?
Oversensing, yes, it is oversensing.
Oversensing?
Yes.
Okay, good. Yeah, and I think the reason is that, okay, so here you have A pace, V pace. After each H pace, you get this little tiny inverted P that seems to be, a little bit after the pacing spike. Okay, so I think it's still here. And the V spike is actually pretty big on this strip, right? So, I think the differential, whenever you look at a pacemaker ECG, you should actually have some differential diagnosis. So what you have here is you have an atrial pacing spike with a P wave that resembles the P wave here. So it looks like there's atrial capture. But then after the atrial event, we expect some type of ventricular event here. And it's not there. So, one is that is oversensing, ventricular oversensing. It's oversensing something in the ventricle and therefore inhibited it from ventricular pacing. The other possibility that we always have to rule out is that is it a ventricular loss of capture? And I think you can then argue that, well, it is not likely to be loss of capture because it didn't deliver a ventricular spike. Because if it did, I would have seen it as it is pretty relatively big. So therefore, the most likely problem here that we also see is ventricular oversensing. Okay. And how about this one? What type of mode is it, I guess?
It is dual chamber.
Good, excellent.
DDI. And
DDI or DDD?
DDD.
Yeah. And why do we
DDD.
say DDD?
Because atrium and ventricle both are paced and it is sensed also.
Yep. So it's pacing both, but there's also one beat here that tells you that the pacemaker is also atrial sensing and tracking it, right? So
Yes.
a sinus beat that came in and it pulled in the ventricular pacing as well too. Whereas DDI, remember that the I is only for inhibit from pacing, it won't be tracking. So by having this beat here where we can see that it's, the pacemaker is tracking a sinus P wave, it tells you that it is DDD. Okay? And is a pacemaker behaving normally? Do we have any concerns? Any sensing problem? Any capture problem?
In the
Where?
fifth complex, there is for before P wave there should be a sense, but it is not sensing.
Perfect.
In the fifth complex.
Not capturing, right?
Yeah, it is not capturing.
Good, excellent. Yeah, good eyes. So that's right. It's lost atrial capture here, and because it lost atrial capture, that's probably why the sinus P came through. Right? Because now it's not, there's no P wave here to reset the sinus node. So now the sinus node finally emerges. So if there's a capture problem, what's the best way to fix it? So what's one thing we should do?
Increase milliamps.
Yeah, that's right. Check the threshold again and increase the output, right? So even if the threshold is good, I would consider building extra safety margin because it's intermittently not capturing. Yeah, very good. You guys are good. Okay, final one. This should be a quick one. Just a quick pattern recognition. Pacing. The boy is complaining of dizziness, and we want to know why. And the nurse caught this strip.
So the pacemaker is not pacing regularly.
Aha. What do we call that?
So, so there is a problem in threshold, probably threshold.
Threshold? But which threshold? Pacing or sensing?
Yeah, failure to sense.
It will be pacing because there is no pacing rhythm.
Yeah, there's no spike, right?
Yeah.
Yeah.
So it is
So
a
it's
pacing
not
problem.
Well, so here is where we're expecting the next pacing spike to be. So this is the pacing interval. This is the pacing interval. So we expect the next spike to be here. But and the spike is pretty big. So if it was delivered, we should have seen it, right? But we didn't see it. So if you don't see a pacing spike when you expect you should, then the pacemaker must be oversensing something, right? If it oversenses something, it's going to inhibit from the pacing. So what we have here is this patient is oversensing. Therefore, there's no pacing delivered. And it's quite a long oversensing. And because there's no pacing delivered, finally the patient came out with their own beat, ventricular beat. And then it paces again. So this is a example of oversensing, ventricular oversensing, inhibiting the pacing. And the way to get around this is to recheck the sensing threshold and maybe make the pacemaker a little bit less sensitive so that it doesn't pick up. What is most likely picking up is just these muscle artifacts, right? There's some muscle myopotential noise on the ECG. The pacemaker is most likely picking that up, oversensing it, and therefore inhibiting from pacing. So you need to recheck the sensing threshold, see if you can adjust the sensitivity to avoid the oversensing. Okay, I think this is it. Thank you so much. You guys did a great job. If you have any questions that come up, please don't hesitate to email me. I'm more than happy to answer any questions that you guys have.
I just wanted to check. There was one question, but you may have asked it already, which was what was the smallest weight of a newborn with total fetal AV block to implant a pacemaker?
Yeah, we did discuss that with the Brazilian doctor.
So, yes,
yeah.
Perfect. Okay, I had stepped out, so I wasn't sure.
No worries.
Great, thank you, Christine.
Okay, thank you. Bye, everybody.
Bye.
Bye.